you are all very welcome joining us this morning. What we're going to be talking about is what does it really mean to wrap services around patients. We all know that the NHS and social care can be quite a fragmented service, which is designed and works around organisations often instead of patients, which can make it a really difficult process when you're navigating your way through a situation when often you're feeling at your most vulnerable and insecure. I've got a fabulous panel working with me this morning. We're going to introduce ourselves and do a little opening for each of us around who we are and why we're here. And then I'm going to pose some questions to them, and you're very welcome to put some questions in the chat as well. I have some fabulous people in the background looking at your questions and sending me some themes. We won't necessarily be able to answer all of your individual questions, but we will certainly do our best to group them into themes if we can. So I'm Julie Thallon. I'm the chair of the Patients Association, and I'll be facilitating this morning. I'm a nurse by background, and so have worked in the NHS and have worked in the NHS for all of my career, and have been working with the Patients Association as either trustee and chair for the last almost 6 years. So I'm going to go round my panel. I can't see them, I'm afraid. I've had technological issues this morning and I'm on my phone, so I'm just going to hope that they're all there in the background. So if I can go to each of my my fellow panel members and ask them to introduce themselves. So I'm going to go in the order that I can see them. So first of all, can I ask Mike Malete, who is representing the patient perspective?
I'm a patient. I am a carer as well. And my name is Mike. I'm from Manchester and I'm happy to be here.
Thanks, Mike. And Minal Bakhai?
Hi everybody, I'm Minal Bakhai. I'm a GP in Harlesden, one of the most deprived wards in London. I'm also Deputy Chief Exec and Chief Clinical and Strategy Officer for a health tech company, building a digital solution to help reduce the fragmentation that exists across our different services, so joining up data but also enabling different teams to act around what matters to people. Rather than in organisational silos. And up until very recently, I was the National Director for Primary Care Transformation and the SRO for the National Neighbourhood Health Implementation Programme, whose focus for me is about helping people live gloriously ordinary lives through integrating services around the needs of communities and residents, but really primarily giving greater agency back to communities, to individuals and residents to help support their own health and well-being.
Brilliant, thank you very much. Rachel Quinn?
Hi, I'm Rachel. I'm Executive Director of Strategy and Partnerships at NASP, and I build nicely on from what Minal was talking about. So social prescribing is about putting patients at the centre, and it's a great example of personalised care. And if you're not aware, social prescribing is about recognising that things like debt and loneliness can affect your health and well-being. Taking Minal's phrase, stopping you living gloriously normal lives. Most social prescribing link workers are funded through primary care. The social prescriber will work with you, find out what matters to you. They'll co-develop a plan with you to meet your goals and your needs, and then they'll use the knowledge of what's going on locally to connect you into support and activities in the community, and they'll provide you with ongoing support. And our recent survey shows that most social prescribers are connecting people into debt support, housing advice, mental health and carer support, but they also might connect you into volunteering opportunities or activities like Men's Shed. And there's really good evidence this works. So an evaluation of 19,000 patients shows consistent improvement in people's well-being if they're working with a link worker. And then an evaluation of the initial rollout found that looking at records from 4 million patients, patients reported better confidence in managing long-term conditions and having their mental health needs understood where there were more link workers. So again, very much putting agency back to patients. The main model of funding for social prescribing in England puts them in GP practices, but there's been some really great pilots elsewhere in the health system, and we think they could have a real impact in places like hospital discharge, for example, for older people, and for frequent attenders at A&E, just a couple of examples. And I'm going to be cheeky and finish with a request from me. We were established to help support the whole social prescribing ecosystem, including community groups, patients associations, helping us to make sure the views of patients who've had social prescribing are reflected in our strategy. And I'm hoping somebody's going to put a link to our questionnaire into the chat, so please help. Thank you, Julie.
Lovely, thank you very much. And last but not least, Stella Vig, please.
Thank you, Julie, and thank you for inviting me onto the panel. So I'm Stella Vig. I am a vascular and general surgeon based down in Croydon, but spend most of my time now as National Clinical Director for Elective Care and Deputy National Medical Director for Secondary Care. Why does this conversation matter? Well, we need to co-produce what the policies that we start to institute at national level and ensure that they work for patients. So just in the chat now was a conversation of I'm a patient and I'm fighting for my right for an operation to be re-referred for my operation. Patients shouldn't have to fight for that. That should be an ability to enable that. And we've talked about the digitization, we've talked about access, we've talked about different ways of working as in social prescribing. What we need to ensure that this is personalized care to the patient. Can we afford a completely platinum service that everything is completely personalized to everyone? No, of course, standardization has to be in the policy, but we need to make sure that we get rid of what we call unwarranted variation. So where there's variation in access that is the right thing to do, we should encourage that. Where it's the wrong thing to do, we should understand it and stop that. But we also need to start thinking about the way that we talk. So doctors are very good at using high-level language. We're very good at talking about low-value appointments for patients. That's quite anxiety creating in a patient. What's a low-value appointment? They're not low-value appointments. Patients want to know what next steps are. But actually we can do them in different ways, and we can make sure that they work for you, whether it's the language that you speak, whether it's the additional needs that you have, and that may not just be physical, that may be neurodiversity, it may be the drugs that you're on that change the timing of when you can have your appointments. We know at the minute that secondary care delivers 120 million appointments. 2 million people use 32 million appointments. We need to personalise care and make it easier for them to access in the way that they wish to. So I'll stop there, Julie, because a lot of conversation is going to be generated in the panel.
Yeah, it's brilliant. Thank you very much indeed. And thank you again to all of my panel members for joining me today for this conversation. And it's a really pertinent time to be talking about this with the modernisation bill that's going through Parliament at the moment, and aspirations are expressed by the government around involving patients in co-production. And it's been our work for many years to make sure that this happens, and it's been talked about in the past, and we still end up with a system, a health system, which is based more around what's convenient for the clinicians and the organisations rather than the patients themselves. And so, like I say, I think this is a really pertinent conversation, and we can use the feedback and the questions that we get from the panel, as well as what we get from other sources, to feed that into the policymakers and the other organisations. And if you do stay for our AGM at the end of this webinar, you'll hear a bit more about the work that we've been doing in the last year and what we've got planned for next year around some of that. So without further ado, let's get into our discussion then. And I'm going to start by asking Mike to give us his views about what it's like being a patient at the moment, and how it feels to try and work your way through the system, and what it's not, basically. So, Mike, can we hear from you first to set the scene for us, please?
Thank you very much, Julie, for this opportunity to give my opinions about what I believe wraparound care means to us. I'm a person affected by multiple conditions, and I'm a patient and I'm also a carer. So I've got lots to say. But in one sentence that I can define wraparound care is a system that's designed to carry the weight from the patient to itself. So how does it feel? The way I look at it, it feels like it's a feeling of comfort. It feels like the system is wrapping around itself, wrapping around your life. Yeah, as a patient, you feel like the system bends towards your realities, your priorities, your likes, your dislikes, and also your capacity. And as a carer, I need to say this about as a carer as well, because this is Carers Week. You feel the system is finally sharing the load rather than adding to it. It feels joined up. We don't like jigsaw. When you're affected by multiple conditions, all you need is just the system is joined up. You need one story, you need one plan, you need one team. People don't want to repeat their history to everyone when they meet. Carers in particular hate to act like couriers for all information about their loved ones. It feels safe, like someone is sharing the risk with you. Patient feels safer because they're not left to navigate crisis alone. As as a carer, I believe the system should be carer friendly as well, because safer care equals to carer friendly. Carers are proactively identified, they are supported, they are treated as invisible. They are not treated as invisible infrastructure of health and care. So what does it, the question that I always ask myself is, what does it take for an institution to ask two questions on admission of a patient? Are you being looked after? Are you looking after someone? Because some of us are patients, some of us are also carers. So we could do with more support. We could do with more proactive identification. The wraparound care will also feel predictable and human. You know who to contact, you know what will happen next, and you know why. A lot of time patients in the as a trust governor, I communicate with patients. A lot of times patients don't know why they are there. As a patient, you should feel the people know you. You're not just an assessment. You should feel cared for. You're not just being managed. So what wraparound service is not. There's a lot to say about this. It's not a label for a new fragmented experience. It's not a pathway that ignores the person's reality, the person's capacity. If you still have to choose to go beyond chasing, coordinating, translating the services, it's not wraparound, it's just rebranding. If the plan works beautifully on paper but collapses in the real world, then it doesn't work. If the plan only works for people who are well, who are confident, who are literate, who are resilient, it's not inclusive and therefore definitely not wraparound. Wraparound care works for people who struggle the most. It's not something that relies on patients and carers who've got extra time, extra resilience, and they can read and write to stay the course of the journey. It's not giving a choice without support. Some people will just hand you over leaflets and website and option without explanation. What healthcare professionals think is empowerment, it leaves patient confused and carers overwhelmed. It's not a system deciding what matters. It does not impose priorities. It lessens, it adapts, it co-creates. Thank you.
So Mike, can I ask you then, how do you think the patient's voice can be heard?
The patient, I think it starts with making the patient priority in your plan. It starts with co-production. Engaging patient and carers at the earliest opportunity to, asking them what matters and act on it. Doing things with people instead of for people is shifting from input to influence. Patient voice become real when it changes decisions. So people could use decision logs to include what patients said, what carers said, what public said, and how they have shaped decisions. So building, what I always say to people should build a simple rule in their way of working. No decision is final until patient and public have reviewed the implication of what we are about to do. Building a diverse patient voice is also important. You need a platform where all people are heard and their input are acted upon. This means you support a shared journey. You are inspiring an approach where it is structurally impossible to ignore patient's voice.
Thank you. Minal, can I come to you, please? Because often the majority of the first access into medical care goes through the GP. So, that could set the standard really for, the GP having the conversation with the patient in the initial stages and understanding what their needs, wants, expectations are, so that can then be translated in a way as part of a referral. So can I just ask you to come back on how you feel that can be facilitated, and then it would be a good start to encourage it across all GPs, but then also how we can work with our secondary care partners to facilitate that too. So can I come to you for your thoughts?
Sure. And I think it's probably worth just emphasising that the complex challenges that we are trying to address, rising long-term conditions, increasing multimorbidity, greater complexity, widening health inequalities, a workforce that feels overstretched and burnt out, can't be solved by a single organisation. They certainly can't be solved by general practice alone. They can't be solved by the NHS alone. They needed a partnership approach, an equal partnership approach with local government, with the voluntary sector, and of course with communities themselves. And so just, I suppose, sorry, I'm in a booth and the light's gone out. So I suppose just building on a bit of what Mike said along those lines, I think what we need is greater coherence. So sharing information, shared understanding, shared decision making, the ability to act together, shared accountability for outcomes. But we also need a shift in power towards places and neighbourhoods, enabling those that are closest to the challenges to shape the solutions. And I think, fragmentation creates friction everywhere. We've heard it for people navigating services, for staff that are trying to coordinate care, and for organisations that are trying to work together around the same population. And I think it's also worth emphasising that those consequences fall hardest on the people who are already least well served by the system, our most marginalised communities. But I also come with a sense of hope and opportunity here. So as I said, until recently, I was leading the National Neighbourhood Health Implementation Programme, and I've very much seen these ambitions come to life, because where places are making sort of the greatest progress, they are creating the conditions that enable this change. They're not just scaling a blueprint, a one size fits all, but they are creating the conditions, the context, the culture for these ambitions to thrive. And that's through building trusted relationships. It's genuine co-production with communities. It's distributed leadership. So recognising the absolutely critical role that the voluntary sector play, that local government and social care play, as well as local partners organising themselves around people and places rather than their own organisational boundaries. But they're also taking a different approach to commissioning. We hear the word strategic commissioning talked about quite a lot, but what they're doing is really moving away from being a manager of a system to being an enabler of a system. So they're providing the infrastructure that allows organisations to act collectively around populations, both through shared data, through digital capability where people can connect as a single multi-agency team of teams and operationalise their ways of working together. Integrated workforce development, but also investing in that community capacity and collaborative space to co-design and co-produce change, and aligning incentives around population outcomes rather than simply organisational activity, and by measuring more than just hospital activity, but what I would describe as whole person outcomes, so the things that matter most to communities. and they create permission and license for everyone to act. So they give people agency to adapt interventions and solutions to the local context. And that means a fundamental shift in devolving power, resources and decision making to those closest to the challenges, and that being governed by people with a long-term commitment to that place and to that neighbourhood. And I suppose on a very practical level, what that has looked like is giving people space. And I mean, by space, I don't just mean physical space, I mean real permission to understand complexity. So traditionally, particularly in the NHS, we often default to programs and governance and reporting and milestones. And then we wonder why nothing much has changed on the ground. But actually, when you create space, you allow people to ask each other, what's really going on in this person or this family's life? What matters to them? What strengths already exist around them? And how do we build on those? So it's real space for neighbourhoods, communities, frontline teams to understand what the problems really are, space to explore what matters most to residents, and space to challenge assumptions and reimagine practice, and particularly space to build those relationships, because that takes time. And I think this is where leadership really matters. It's to resist the temptation to specify a solution or over specify a solution too much too early, because when we define the solution before we really understand the problem, we limit the innovation, the ownership and the local agency that we're trying to create. And what we've seen is that when you do create space, that people begin to come together differently across sectors, across roles, across communities around a shared purpose, and a collective starts to form around the common good, and that changes how people show up and how responsibility is shared. I think secondly, I'll just emphasize a do with rather than a do to approach. So again, traditionally our systems have assumed that intelligence sits at the center, in experts, in data, in strategy, but actually intelligence is distributed. There's intelligence that residents, families, frontline staff and communities hold that, you know, experts at the centre can never hold. And so an asset-based approach really starts with asking different questions. What strengths already exist here? What is already working? And again, you know, how do we support and enable that to go further? And I think we have to recognise neighbourhoods and citizens or residents as sites of intelligence and work with them as equal partners, not just consulting, but really co-creating, as Mike said, and providing the resource and space to do that, because that's when we unlock really innovative solutions, and that's how we build the trust and behaviours that the health and care system alone could never generate. And that brings me on just quickly to the third thing, which is traction. So a lot of our transformation efforts fail because we try to move quickly with urgency and speed before we've built trust. And I think we've got to really value trust as core infrastructure, and you can't contract for that. You can't manage for trust. You have to invest time in it, sitting together repeatedly, understanding together, and you know, activating people around their own health and well-being, and activating staff as well, and committing to some long-term goals. And while that can feel like it takes time, it really, and I've seen it, it allows acceleration as you go forwards, because you've not just you know, created activity, you've really built that alignment together. And then fourth, I think it is very much a test, learn, grow approach. So like MDTs, multidisciplinary teams, integrated neighbourhood teams, none of this arrives fully formed. They evolve and they change over time. So instead of building lots of complex governance and trying to design everything up front, actually the most effective approaches allow teams and communities to learn their way into the work, try things, adapt, learn from what works and what doesn't, and then evolve governance to support learning. I think we've got to value learning as a method of implementation and create the safety and the permission to learn, to innovate, to fail and learn from that. So continuous learning approach and improvement mindset. And then I think the final thing, and I mentioned it before, is we have to enable scale by not just copying what works in where I work in Harlesden, in Manchester. Change just doesn't behave like that. It's really understanding what are the conditions that allowed something to work here, and how do we create those conditions elsewhere. It's a bit like, I always use this analogy, it's like taking a beautiful rose and the petals from a rose and then scattering them elsewhere in your garden. It doesn't just create another beautiful rose. You need the roots, you need the soil, you need the sunlight, you need the conditions that allowed it to grow. And so I think, what makes change successful is developed by a place for a place, and that's exactly why it is successful. So we need a completely different shift in how we think about change as we move forwards.
Thank you. I wonder, Stella, whether you can just build on that, Rachel, rather, and just tell us how you think the voluntary sector can support patients in making sure their voice is heard.
Yes, that's a really interesting question. So I think I would flag that. So while link workers are really important for people for co-producing a plan and supporting them to connect in with their communities, whether they're in primary and secondary care, I just wanted to start by highlighting that lots of the activities that social prescribers are referring into, the NHS doesn't normally pay for them. They're often run by volunteers. It's a bit of a flaw in the system. And we're seeing volunteering declining and philanthropic funding also declining. NASP's been developing and supporting models and discussions in government about getting funding into the voluntary sector for those kind of activities that are really making a difference for the health of communities. So, for example, as part of the Neighbourhood health programme that Minal talked about. So I think I'm making my points against that background of that lack of support for community faith groups that are providing that. So I think it's really important for a start for there to be community engagement and use of data that Minal talked about to indicate where the need is, and at a local level in primary care, just making sure that social prescribers have the time to go out and understand what's out there and where the gaps are. I think one of the challenges is the data and the communication. So feeding back the sort of connection between social prescribers and community groups about what's working. Each community group will have its own way of getting patients' feedback and patient views in, and I think we might talk about sort of data later. Joining up that data is really important so we can see what's actually working, and then obviously the feedback that the social prescriber will get about the activities. I wanted to just, if I can just quickly hook on to that question about communities as well. I think the other important thing to make about community groups is that we should really be encouraging people to connect into their community. They don't need a referral, but it's likely to help their well-being. Also, very important for prevention. Also, we know that volunteering is really good for your well-being, as giving you a sense of purpose. So in terms of perhaps reversing that declining volunteering, even if it's just around fundraising. But I think you have highlighted a real issue with community groups, and they'll have a diverse way of doing it. But I think it's important that social prescribers are finding out how they are getting how individual community groups are getting feedback. Does that answer the question, Julie?
Yeah, thank you. Before I come to Stella to talk about what it's like in hospitals, because I think that's another really important area. I just wanted to bring it kind of like down to a more kind of individual patient level, because we've talked here quite a lot about communities and kind of how organisations work and how we can kind of change on a more global level. But just bring it back down to individuals. And an experience that I had when I worked in community services was we employed a care coordinator to work in a GP practice, and that person, albeit that they were paid, I get that, Rachel, but they were paid, and they were asked to take on a small caseload of patients who were frequent users of services, whether it was the GP, whether it was the ambulance service, where A&E, whatever it was, they were frequent users of services. And these care coordinators were asked to kind of develop a relationship with them to understand what the motivation was around the multiple connections with services. And after about, because I managed them, and after a very short period of time, I had a particular conversation with one of them, and we were talking about how well it was going. And she said, yes, they'd got a particular patient who was, contacting health services in one way or another 30 plus times a month. And the GP, who was currently caring for this patient, because they tended to rotate because it was quite difficult, asked the care coordinator if that patient was all right. She was worried that they'd passed away because she hadn't heard or seen anything of them for a long time. And actually, because the care coordinator was going in and was working with them and helping them to manage all of the stuff that was going on in this person's life, which had absolutely nothing to do with their health a lot of the time, it was just their management of everyday activities, and had helped this person to have a much more secure, fulfilled, enjoyable life, which meant that they weren't. So that's what I'm trying to get us to, really, which is I get that we need big system change, but actually on an individual patient level, having that conversation at the beginning and understanding what their motivations are, what they want, and how can we do that? Because that's often about training, about individuals, about sitting down with people and taking the time, waiting for a system to change, or even working really hard to make system change, which I know you're all doing. We've still got the patients like Mike in the meantime that are just trying to make sure that somebody listens to what they're trying to say.
Yeah, I would agree, Julia. And I think there's a number of personalised roles that came in 2019. So the care coordinators, social prescribers that are called lots of different names, and the health and wellbeing coaches. And I think it's completely your point. I would argue that was quite. I mean, it'd be interesting to see what Minal thinks about that. I would say that is pretty impressive system change. I think we've just got to maintain it. But I hear lots of stories from GPs. Minal might have them of exactly the same. It sounds really simple, but just putting the patient at the center. What matters to you? What is affecting? What is stopping you living that normal life, as Minal put it? I think, glorious, wonderful, normal life. So I think that's really important. It's really important that we don't see pressures on funding and mean that those roles disappear. The other thing I would say, not only is it, I've heard exactly the same story as you had about like, has that patient passed away, but I haven't seen them. But actually, what you do sometimes see, which I actually think is equally as important, is sometimes at the beginning of a connection in with a social prescriber, you'll see GP appointments go up. And that's because perhaps it's somebody who hasn't engaged with a GP that often, and there are actually genuine health clinical needs that they need. So I think, again, it's all about if the patient, what matters to them, what's going on in their lives is at the center, you can solve a lot of these problems, I think. And it's more about, it's not just, there's a lot of data around it saving GP appointments. It's not really that. It's just making sure that patients get the right care for them as quickly as possible. So yes, great, and a great example. And yes, hear that a lot.
Yeah, one of my other roles, I work for one of the ambulance trusts, and we hear this a lot about the people who frequently call ambulance services. Nobody's actually working with them to understand why they feel that that's the only way they can access any kind of help, regardless of whether it's a medical emergency, which frequently it's not. But to deal with that, Stella, can I come to you and just ask you about, from a secondary care perspective, how? Because if people are coming in through their GP, or even if they're coming in as an emergency, sometimes they don't have anybody to advocate for them. How do we make sure that their voice can be heard, and that we don't do what you said in your introduction about assuming that we're the ones that know and we're the ones that need to make the decisions for them?
Julie, thank you. And I think, let me divide that up into three. So first of all, national have to create the conditions where people change their thinking. So at the moment, if you go to a board, well, they'll be obsessed on the RCT numbers, the cancer target. They'll be talking about 4-hour waits in ED, all of those conversations that are there. But actually, those are numbers. They're not about people. And there will be a quality strategy the Patient Association have been involved in, which talks to performance is important, but actually the outcome for patients are even more important. And actually just bringing that conversation to play at national level and saying to chief execs, chairs, actually you can obsess about your numbers, but you also need to obsess about your outcomes is actually a really important message. So that's happening at national level. And I think that's important. And of course, we've got conversational patient experience that comes into that as well. And they're being played through all the policies that are being driven. But I think what Mike said at the very beginning was so powerful. Policy on its own will fail and is guaranteed to fail. So what do we do as we take this down? So if we take this down into region system, and Minal talked about strategic commissioning, if we just change a surgical pathway, we can do that. We can shorten the time frame. But actually what we're not doing is talking to the patients about what is it you actually want? What's a shared decision? What are the things that are the car parking that doesn't work when you want to come in for an appointment, or the fact that you haven't got the names of your consultants and don't know who to approach or which team. What is it in the pathway that actually is creating discomfort, harm, and that repeated conversation? So we know there are really good examples. So women's health hubs are really good examples. Talking to women, where do they want their care? How do they want their care delivered? Do they want choice in terms of the options that they have? What is the shared decision making? Not every, and if you talk to a surgeon, we've been trained to operate. We need to be trained to have shared decision making, and actually that what matters to you is not a conversation that is a regular conversation in organizations. So the what matters to you is really important. So you can strategically commission the right thing that only can co-produce with our citizens, and we can see really good examples of that happening. But then you come within the organisation, within a provider, within a hospital. The conversation there again, it is really easy to fall back to the activity conversation. So, what are our did not attend or was not brought rates? What are how many patients are we seeing in clinic? How many patients are going on to what's called a PIFI pathway? Actually, there's a conversation of shared decision making and learning. And again, Mike, you said that. I think Minal, you said that. Learning from what has happened. So if patients are not attending, what is it that's stopping them from coming? Who is enabling that patient voice to really co-produce and redesign the service so it works? And Rachel, I think you taught me a long time ago, if we can design the processes that work for the homeless community and our Romany community, actually you will get it right for just about everyone else. And we need to redesign our services for the people that struggle the most to use them rather than the ones that find it easiest. And that has not been a conversation that's been played out really loudly, but is beginning to happen and is beginning to accelerate. The other conversations are, if you look at cancellation rates, so what gets me out of bed in the morning? I'm a surgeon, I'm a doctor. What gets me out of bed in the morning? Why did I go into medicine? Because I wanted to help people. And we've forgotten the fact that we're in a people business, I think. And so nationally, our cancellation rates in theatres are at 10%, which is dreadful. 1 in 10 patients will come through. I had an operation in 2016. I was waiting for an ITU bed. An ITU bed was available. I spent all of Sunday night fretting whether my operation was going to be cancelled the next morning. But we cancel 1 in 10 at the moment. We need to bring the voices of the patients into the room, and the carers and the families, to say, you may have cancelled patients this week, but this is the impact on the patients, and actually start to learn from that and learn from that rapidly. So I think we've now set national conditions and principles that will support what we want to do. What we now need to do is to translate that into the very front end of the service, because that's where we can make change really quickly with the people that we treat every single day. And coming to a hospital, and there is a patient conversation in here, the understanding that coming to hospital and seeing, I'm going to say in inverted commas, an expert, because there's a huge amount of talent across the whole of the organisation. It doesn't just reside in doctors or in secondary care. Coming to hospital may not be the right thing to do. And actually accessing your care in the way that's right for you, in the environment that's right for you, is what we need to do now. That's going to have to be our nirvana. So I'll stop there, because again, conversation's important.
Yeah, no, that's helpful. Thank you, Stella. And I can, because I'm doing this on my phone, I can only see the first few words of people's comments, but a lot of them are coming up saying that they're agreeing with what you're saying. So that's really helpful. I'm going to come back to Mike in a moment just to ask for his reflections on what's been said so far. But just before that, can I, hopefully Orla is ready to do a poll, but can I just ask everybody if they could vote on a quick question for us, which is, how confident are you that the patient voice is currently informing NHS decisions? It'd be really interesting to know what you think. Thank you. I think that's everything. One or two people say that they're very well. One person is very confident about it, but the majority of you are either not very confident or not confident at all. And I think that gives us a really indication of where we're at, and actually, what we're talking about today and why it's so important, because most people, I think, from what we've seen here, certainly well over 3/4 of our small but perfectly formed cohort of people on this call are not confident that this is the case at all. So, Mike, can I come back to you then and just ask for your reflections on what's been said so far, and how you feel that relates to you and your personal experiences?
Yeah, sorry. Thank you. My main takeaway today is simple. The intention to wrap services around patient and their carers is there. But I know from experience, the intention on its own does not create impact. I mean, the key point I'm trying to emphasize here is that people do not experience services in organizational silos. Like when you've got multiple conditions, you don't experience the service like that. You experience one life and one story. Now, for people living with mental health illness and other multiple conditions, for those people who are caring for somebody they love, the system is just not only by its strategies or structures, but by how it feels when something goes wrong, or at 9 o'clock in the morning when they're trying to get help and every door is shut, or when it leads somewhere else different. Now, what I can say to people is that if we want wraparound care to be real rather than rhetorical, it means reducing the burden on patient and carers, not simply redistributing it. It means continuity that is felt, not just promised. We need compassion that is consistent, not conditional. It has to be designed based on people's lived realities, meaning you have to involve people with lived experiences from the start. So my hope is that we have to live today with a shared commitment to build a system that holds people rather than one that expects people to hold the system together. When care is truly wrapped around patient and their carers, it becomes safer, it becomes kinder, it becomes human. And these are the real tangible benefits that we want to see and we want to enjoy.
Yeah, thank you. And you brought up a really important angle, Mike, around advocacy. So you're a carer for somebody and you can advocate on their behalf. Other people, elderly, vulnerable, the homeless or disadvantaged that Stella was referring to, people from marginalised communities, they may well access health services, or often not, but they have nobody to speak up for them on their behalf. And if they're unwell, feeling vulnerable, or being spoken to in a language that they don't understand, even though it is their first language often, because the medical language can feel really impenetrable, how do we make sure that their voice is heard? Because for all of us on this call today, I'm sure we're capable of making sure that we speak up for ourselves, but it's not always possible, even for those of us who feel able to. And I just wonder what you thought about that, and then I'll come back to the other panel members for their view about how to support people when they can't speak for themselves and they don't have an advocate. Do you have a view about that, Mike?
I think supporting people who cannot articulate their needs starts with actually identifying who's supporting them. And and that in itself is actually the key to everything, because carers are the ones that can be able to tell you when they're going into a crisis, or when situation is not happening. So if you not identify if somebody requires help, or you've got somebody that's supporting them, then you're never going to know. So I think that's very important.
I think it is, and you're right, of course. But I'm thinking about people who don't have somebody like you to support them. So I did some work in a former life around reviews of people who died with who lived with a learning disability. And one of the biggest differentiations between why people with a learning disability generally die younger than somebody without is because they don't have an advocate. They don't have somebody who's working on their behalf to make sure they stand up for them. So can I come to Minal, because you must come across this in your GP work, and I just wonder what your view might be about advocacy and supporting people who can't help themselves.
I suppose often for those individuals, I am their advocate, and I think this comes back to trust and relationships. So, I guess general practice, often when you're a GP, you have a long-term commitment to working in the area that you work in. I've been in my practice for 15 years, so kind of an anchor within the community. I know my community that I serve very well. I walk the streets of those communities, and over years have built up strong relationships with individuals and the community. So often general practice can be that anchor. I think the challenge is that over time, as demand and complexity is increased, the time for relational care has been reduced. There's a significant amount of time now spent on administrative tasks and system asks and things like that take away time from, relational care. And so what we have started doing, as Rachel described, is that we have brought in trusted community roles. So there could be community leaders, we have community health and wellbeing workers, we have social prescribers, people from those communities. And we, for example, where I work in Harlesden, it's very deprived, you can kind of allocate those individuals to the most deprived households, to those families that need most support. And they, over time, build those trusted relationships, and they become an extension, of us as a team. They increase the relational and listening capacity of the system. They support them not just with their medical needs. Often it's food poverty, temporary housing, education. There are a whole, bunch of really important things that happen in our lives, much wider and most outside of clinical settings. And so it's through, and of course, the voluntary sector being critical and key part of that. And so I think for us, I can describe multiple areas that have got really good practice and have really invested in that. But what we don't have, and I think was in the chat, is that it's not available everywhere equally. And that requires a different systems approach around how we allocate resource. Because I think what we often focus on is, delivery of a medical model of care, and not that kind of whole person, what I describe as a biopsychosocial model of care. And that is actually fundamentally a mindset shift and a cultural shift. And then we can start to allocate resources to where that makes the biggest difference, which will be in communities, with the voluntary sector, with primary care, with community services, with social care, with carers, formal and informal carers, that really understand people's needs and therefore can then advocate for them in a variety of ways, depending on the support structures that they've got around them. And I guess one of the things, I just as an example, Julie, that I'll give you, because there's comments about, what's the person's experience really look like. So just last Thursday, I was in clinic. I have I'll call him Walter. He's a 90-year-old gentleman, and he lives alone. His wife died a few years ago. And over the last 12 months, he's kind of become withdrawn, depressed, cognitively declined, and that linked to mobility problems, and ended up going into hospital quite a few times. And actually, when we got to the bottom of it, he has a tremor. And when he went into hospital, they did a falls risk assessment, and he was on a medication that could make you more likely to fall, but it also improves your tremor. And so the hospital didn't ask what mattered to him. So they stopped the medication, and his tremor got worse. And he was unable to confidently eat or drink, something very human, something very social, something obviously very important to him and us. And so we then made a shared decision to restart that medication. And suddenly his confidence over time came back. We wrapped around some support from voluntary sector and social care around him, and he's living independently. He didn't need a new care pathway. He didn't actually need, the intervention was what matters to you conversation, nothing more than that. And so I hope that starts to demonstrate, and I was his advocate. He didn't have anybody else. So he and I advocated for what mattered to him. And I suppose I see that across the system and in different guises.
That's really helpful, Minal. Thank you. And I think it's a really good place to get us to with another example of just what it's like if somebody is taken by the hand and supported through this journey, and regardless whether they need that level of support or not, the offer of it and the availability of it is often what makes a difference for people to help them through their journey. I'm going to do another little poll, if that's okay with everybody. If I can just ask you to have a little think about this question for us, if you could, before we finish. What single change would make the biggest difference to patients in the next 5 years, do you think? Care that's designed around the individual, not the system, faster, fairer access regardless of where you live, patients having real influence over decision making, or better coordination between services. What single change would make the biggest difference to patients, do you think? Thank you. So I think that's probably it. So we've got a fairly even split then between care that's designed around the individual, not the system, and better coordination between services. I think there's votes for the other two areas as well, but I think that's really the crux of what we've been talking about this morning, isn't it? Which is, if individuals had the care wrapped around them, not the system, and then the coordination for their journey was better, then that would make a really big difference. So that's potentially two changes rather than one. But this kind of feedback is really helpful for us at the Patients Association, because we can feed that back into the conversations that we have with people who develop the policy and try and make the change that's needed, and hopefully we can get some of this included in the modernisation bill and what have you. We're coming to the end, I'm afraid, and it's been really interesting talking to all of our panelists this morning, and I want to thank you very much for your interest in talking to me and each other in front of our audience, and for sharing your views and your aspirations, because it's great that we've got people like you that are really working hard to try and make the change that we need. And also particular thanks to Mike for coming on and sharing your experience, because that's been really helpful for us, and I suspect for our audience as well, to hear what it's like for you being both a patient and a carer, because you've almost got the double whammy of trying to navigate through the system, not just for yourself, but also for whoever it is that you care for. So thank you very much to all of you for joining us this morning.